has to go around the mother's breast like to make a suction, and then has to press with his tongue. This is a labor. That's why healthy baby breaks the sweat while they're eating.
Wow.
It's an exercise. He has to press to get the food. But by pressing, he's expanding the arches on all directions. 4 months old. So either he breastfeeds or he dies.
In nature.
In nature, right?
Yeah.
As a matter of fact, 150 years ago, if baby is born and has a tongue tied, it was only one thing. It doesn't make it. So it was a life and death.
Failure to thrive.
Right? And the midwives would grow their pinky nail and sharpen it like a scalpel. So baby is not going on the mother's breast to eat right away. They knew. Bum. They cut it, put it up, baby lives.
The midwife did the frenectomy in those days with a nail.
I've had a patient that is 45, and she just freaked out on thinking about MARPE.
You showed her that and she freaked out?
Yeah.
That's a custom MARPE from Partners.
Yes. She said, I just cannot fathom this. So what I do? I'm going to tell her not to treat? No. She has major problems with the headaches, with the depression, with all these kind of things. So she said, listen, can you just line up and do something for me short of this? I said, listen, I really think that not only that you need expansion, you need actually MMA for a whole enchilada. But not everyone is for a whole enchilada. Yeah. So we have to go step by step until patient says, hey, I'm okay with that. So I did an ITI appliance for her. And it expanded, and I'm working out the conventional ortho with her doing a myofunctional therapist here. She said that she feels that her breathing is like 60-70% better than ever.
There you go.
She actually medically feels better. She said that she has not had a headache in the last 5 months since we started treatment. Now, is she optimal? No, I know that. And she knows that. And I know that the danger of a relapse is there. Now, is it going to be 100%? Probably not, but it is possible. Those are all things, the choices for my patients. I don't shove it into their throat, you know.
So then there is also a chemical component to bad food. It's not just that it's soft.
Preservatives and sugar.
Preservatives and sugar will also, even if it's tough sugar, like jawbreaker candies.
You get a stimulus in the term of the biophysics, but you are making a big rack in a biophysiology.
You're taking one step forward and one step back.
So you're trading one risk for another. What's good about it?
All right, today we are going to visit Dr. Kuljic's office in Beverly, Mass. Dr. Kuljic is an airway-focused dentist that I met at Dr. Lipkin's MSc Custom MARPE course. He invited me into the office to check it out, see his practice, maybe check out some of his tools, some of his cases, just see what he's all about. So I'm not really sure what to expect, but we're going to find out. Let's go in and meet Dr. Kuljic.
My son was actually talking to me about you the other day. He was like,
oh,
Mom,
really?
Do you know what mewing is? He's like, I was watching this JawHacks guy, and I was like, no, I'm actually going to meet him.
That's so funny.
Doctor!
How are you?
Here's Dr. K.
Oh, you're coming with a. No, sorry, I'm sorry.
Ah, of course.
Hi.
That's how it goes.
No problem with me.
Welcome to our practice.
Good to see you.
Good to see you.
Good to see you. Yeah, beautiful office.
Well,
plenty of parking.
Well, that's how I started.
Yeah.
That's how I started 25 years ago. Now we're kind of moving along.
Wow, that's good. That's good.
Yeah.
Yeah, my brother's wife lives in Beverly. I've never actually been to Beverly, but it's not too far from my home actually. It's right here. So,
here we go.
We're looking for a dentist for our daughter that's going to be born.
Yes, you're not recording me. Come on.
That's what I do.
Yeah,
That's what I do.
I just want. Hey, I heard you had the MMA then.
No MMA. I had SFOT.
SFOT, okay.
Yeah.
Becky said he just got the MMA. I said, oh.
No. I had one quadrant SFOT done with Dr. Rabinowitz in Framingham. I don't know if you know him. He's friends with Dr. Lipkin. Actually, I put them in touch with each other about 3 years ago.
Oh, yeah.
And because Dr. Rabinowitz did my tunnel graft, because I had some damage with my tooth-borne expander. And then I saw Dr. Rabinowitz. He did a tunnel graft after they refused to do SFOT back then because they didn't want to flap the area because it was too compromised. There was like no bone left. Dr. Rabinowitz did that. Then that's how Dr. Lipkin heard of him because I told him that Dr. Rabinowitz did it. And now Dr. Lipkin and Dr. Rabinowitz work together for SFOT cases.
Nice.
So, yeah, I just did that about 2 weeks ago. The swelling is gone. It wasn't too bad. No pain. Some swelling that happened after.
Yeah.
But easy healing.
Yeah.
And I guess now I'm just curious to see the results. You know?
Yeah, you see, but I have a question now. I didn't ask too many questions when we were there. Okay?
I understand. Yeah.
You know, I didn't want to really rock. I asked some, and then you see it's like kind of you know so.
Yeah.
So you see, so one thing. You probably, when I show you now, I do so many of those airway screenings. Airway screening is the ultimate thing that really help us in the bigger picture. We cannot solve the problem, and I think a number one problem in all airway self-pronounced experts, okay, whoever I'm not, is that they still underneath in their mind they hang on one procedure, one this, one that, and it's not. And they measure their success within the dental domain.
How do you mean by that?
For me, oh, I expanded you 17 millimeters. Oh, I did this tooth. I add the 3 millimeters of a bone. But it's all that. But still does not mean that the outcome is going to be good. Because the problem is in a medical domain. But it is elusive. So instead of asking about the sleep, about HRPO, about the signs and symptoms and shared risk factors, for example, GERD, coldness in the hands and feet, constipations, neck and shoulder aches, lower back, those are all things that are in medical domain. So what good does it do? And it of course does something when we do something in medical dental domain, because that's what we are trained for. But you still have, if you still continue having the problems with the breathing or sleep, your life span at least has not been expanded.
Right.
So what good does it do? What is it going to written down on your tombstone? Here lays the one who had 72 millimeters between the molars.
Right.
He just didn't live long enough. So you see, so our measurement should be in a medical domain, I think.
Sure. Expansion is only good if it can improve health outcomes.
But you see, the expansion, the reason to get to the expansion is this is dysfunction of the scar tissues. But how did it come about?
Yeah.
It's a phenotypic problem, right? By my brain stopped. But phenotype,
Sure.
plus soft tissue dysfunction. I mean, if we
What do you
were
mean
doing,
by that?
for
Soft
example,
tissue
that
dysfunction?
little baby that's going to be born hopefully soon, right?
Yes.
Okay,
Hopefully.
hopefully, okay. So that little baby has no clue what is going on. But the moment it comes out of mother's womb, it goes on a mother's breast and mom has a milk right there. Now it doesn't. So think about it. And we think only because of food, and food is important. But way more than that. What if baby cannot get food? Is it mother's fault? No. So many mothers say, oh, I didn't have enough milk. No. It's baby has to suck out of it, right? But if the baby is tongue-tied, guess what?
No sucking.
That's what I'm saying. If baby doesn't take milk out, milk doesn't get produced. But mother, rather of course blaming the baby, will blame to itself,
Sure.
to herself. So, but that's a one problem. So
that would be a soft tissue dysfunction.
Absolutely. He is born to put that tongue up and nurse. And in order to take a food, man, that kid has to really work hard to get the food out of it. Nature actually made it so uniquely that when you think about it, it's go to your CVS and buy a bottle. That nipple on a bottle means nothing comparing to mothers. But baby, in order to get the food, has to press. But pressing the maxilla, it opens up. It drives in that direction. As it opens up, the floor of the nose drops down, baby breathes. So you'll see, hopefully, that baby is healthy when it sleeps, you put it in, and lips are closed. That's how we should all live all our life. Now, sometimes the problem is a tongue tie, right?
Sure.
And as a matter of fact, 150 years ago, if baby is born and is as a tongue-tied, it was only one thing. It doesn't make it. So it was a life and death.
Failure to thrive.
Right?
Yeah.
And midwives would grow their pinky nail and sharpen it like a scalpel. So baby is not going on a mother's breast to eat right away. They knew, boom. They cut it, put it on, baby lives.
The
Think about
midwife did the frenectomy
Yes.
in those days with a nail.
With a nail.
Wow.
So think about it. So this is actually where the thing starts. But we think we're going to trick the nature by making pacifiers, formula and stuff. It's not only food. Yes, food, but not only. It is the growth and development. But what about if the kid has? It could be other reasons, right? Kids say like doesn't have a problem with a tongue tie.
What else?
But
could it
still, it could be like some allergic reaction. I didn't know. I didn't have a problem nursing. My mom told me she was nursing me 18 months. Well, guess what? They had to remove my tonsils at the age of 3. Back then, in late 60s, it wasn't fun.
be? No, I bet.
Okay. So why? She said, well, they kept giving you antibiotics all the time, and they said, listen, we got to remove those tonsils. So the tonsils, in order for tonsils to overgrow, that means that they were doing, instead of being the last level of defense on the breathing, they were first. That means that I was breathing through my mouth. Mm-hmm. So how come I was breathing through my mouth? I didn't have a problem in the beginning. And I kept thinking.
Some allergen in the environment.
Well, here we go. My mom and dad both smoked at the time.
Everybody smokes.
So think about this. But it was
This
the
was in
trigger
Europe?
point. It was in Europe. It was the trigger point back then. And the moment baby, or even adults, but baby, particularly newborns, the moment they start breathing through mouth, before in a week or two, they turn completely opposite of what is natural, obligatory nasal breathing. So now, what does he do if you expand even with the MARPE and do all kinds of phenomenal things like Dr. Lipkin? If you don't change the breathing pattern, but you have to teach that person. That person is now 40. It's been only 38 years that has been breathing through my mouth. So you have to build up the engram that. Do you see what I mean?
Yeah. Creating the space only gives you an opportunity to have the better function, but you still need to train the
there
function.
are a lot of other things. So without really going into structure, function, and behavior, we're not winning this game. It's too complex. And that's why it's so many. I don't even know how it's going to be fitted into the medical or dental system. It's going to be like aberrations and those outliers crazy as Dr. Lipkin, myself, and probably a few hundred of us.
Yeah. I think it is going to be the dentists that lead the way.
Yeah, but how do you do that? I mean, there's only that much we can do, right? I mean, yes, I have two myofunctional therapists. My hygienist are myofunctional therapists, and my wife too. She's dentist and myofunctional therapist. Mm-hmm. And we do all kinds of things, but still, I mean, I'm not the ENT. I'm not the sleep specialist.
Do they teach this at dental school?
Are you kidding me? I went 2 dental schools, one in Europe, one here.
Wow.
I did probably about $250,000 dollars in a continuing education the last 20 years since I graduated USC. I heard about my functional therapy first time maybe 5-6 years ago.
Yeah.
So it's not, because we have, you see, think about this, and I'm kind of more like on a philosophical level. I'm thinking about when we are calling our science, we call it dentistry, and we semantically we're thinking about dent. Dent is a Greek word for tooth.
Tooth, teeth, sure.
So then semantically you sway yourself to the teeth. Hence, if I handle the teeth, whatever, position-wise, drilling-wise, whatever, I'm going to solve the problem. As we see, they told me even in Europe in the 80s that we're not going to have a business anymore because fluorization and all this kind of things, cavities is going to be eradicated. That's what they supported at the USC in the mid-90s also. Well, let me tell you, we have more cavities than ever in the history of our species.
Why? Because more mouth breathing, worse food?
So, the whole lifestyles, food, all kinds of things are influencing tremendously. We don't.
Do you think mouth breathing is a major contributor to cavities because of the dry mouth?
I don't think mouth breathing, it's just the consequences of aberrant breathing. You see?
Acid?
Acid, absolutely. But that acid is not through the mouth breathing. Mouth breathing just exacerbate that. But you see, when you sleep, whoever, and when we have this respiratory distress, to take another breath so that we can make up for the lack of oxygen saturation. So we have like, and this is that respiratory distress that happens in you. But you have a paster, and when you're laying down, it just leaks. So this is not too much acid. It's just that you paste it out.
Right.
And then it goes and it leaks in the mouth.
You're talking about creating a negative pressure in the esophagus that draws acid.
Absolutely. And then it goes, and then you are breathing, so you don't even have that much of a buffering effect that you get with the saliva because breathing through the mouth. You're drying. Sure. Now this is a compounding effect. And that's why we have people coming on and on and on every 6 months, and it seems like it's a never-ending story. We are just drilling, filling, and billing, and we are not solving the problem. Add to this clenching as another escape motion for distress.
Clenching.
Yes.
Yeah, that wreaks havoc on the teeth as well, right?
And then that's how you get it.
Does mechanically wearing the enamel by clenching and grinding, does that lead to greater cavities in tooth rot?
I wouldn't go that far. So usually cavities that first stomach acid is probably just about one of the most potent acids in nature. Maybe short of battery acid.
I think it's hydrochloric acid.
It is huge. It is like a pH 2.5 or something.
Yeah,
it's
it is very
tremendous,
very
right?
severe. Yeah.
So when it leaks and it soaks your teeth for an hour, 2, 3, it actually volumetrically melts your enamel. So you don't see it. This is like putting the ice cube outside. But if you come back in 10 minutes, you don't see really a difference. But try to come in
an hour.
In 2 hours, it disappears. So it's a volumetrically that sways us, right? But when we see more and more yellowishness, that means that the less and less enamel. Whiteness of the tooth comes from enamel. The less enamel, the more yellowishness from a dentin. So that's like a first sign. So much for that. But once it reaches to dentin, then if you have really significant acid problem, it actually corrodes and makes a pitting, because at rate of biochemical impact is higher than biomechanical rate of
the acid
clenching.
is worse than the grinding.
Yes. Now you slow down the acid, but the grinding continues, but then you have flattened surface. So those are all little things that we can kind of decipher at least the extent of how certain things come about. And then start building it up. I'm not saying I have a magic wand how, but the more I'm dealing with this, the more I realize the complexity, and every day is a humbling day.
How do you mean by that?
I mean that every time I think I manage one thing and this is going to be done, then my numbers, because I like a metric, right? I'm a dentist. But medical metric does not add up to it. Because I have people who are telling me, Dr. K, I feel like I have oxygen tanks on my back. I'm breathing now phenomenal from MARPE or whatever I did. Yet at the same time, when I ask them, how's your sleep? It's a little better. What do you mean a little better? I thought I solved the problem. Because I thought that if I expand, they're going to sleep better. Well, there are a lot of other things that are playing into that.
The function side.
Yeah. Oh, yes.
Maybe those patients need more myofunctional therapy to learn to use the space.
It is multifactorial. It's not one thing. It is the craniosacral therapists, myofunctional therapists, ENTs, sleep specialists. I mean, let's face it, nutritionists. We have, we don't know. I mean, we use with our patients HRPO as our kind of standard, but certainly not to to overpower the knowledge and influence of a sleep specialist. Because
What's HRPO? Can you explain that?
yeah, high resolution pulse oximeter. It just carries through the night and it and measures in a split second variations of saturation of the oxygen saturation in the blood, and at the real time also a heart rate. But it also gives us the autonomic arousal index and all other things. So while this is not really a sleep study, it darn gives us a good clue. But we really don't know. Some of those have maybe central apneas. That's dangerous thing. So we have to be cognizant. We have to deal with the sleep specialists, with the PCP. But you try to find sleep specialists that even get to the phone, let alone to. How about the ENT?
Yeah, good luck with that.
Oh, well, that's another...
Does that tool help you identify RERAs? So in younger patients that have UARS, that maybe they're not having oxygen drops, but they're still having disturbances, can you pick that up on that test?
That shows something that is, they say it's like kind of a commensurate to AHI, like they call it respiratory distress index.
Yes.
So it changes, yes, respiratory distress index, it shows. Now again, you have to understand, we use this as a trending in some large aberrations.
Sure.
I certainly wouldn't dare to call myself as a specialist who can make diagnosis based on this, but it gives me a darn good clue.
Mm-hmm.
The level of distress of that person. Mm-hmm. But that's a medical domain, that's not dental. How about the myofunctional therapy and how do you measure if your tongue is strong enough? What good does it do, the expansion, if you can't put the tongue up? How do you know? Or you say, I'm doing it. How you're doing? Little John go home. His mother worked all day long and bring him over here. John is not doing anything during the day.
Right.
And then, well, I know he's doing it. Well, Mrs. Jones, he's not doing it because it's not strong enough. What do you mean? So when you don't have a metric, it's them against you. Now we have a metric.
You have a way of measuring tongue strength?
Yes. So now all of a sudden, you put some metric, it's completely different. Again, it's not dental metric. So it's a bigger picture. It's not only one stuff. Oh, I'm doing this procedure. Oh, I'm doing Invisalign with this. I'm doing brackets. I'm doing whatever. This is dental thinking.
Sure.
But I think that dental thinking is where we are now. I mean, we have more cavities. We have more teeth that are breaking. I mean, it's just going on and on and on. I mean, good for dentists, but it's not good for... we are actually having more problems, that seems to me, than ever before. But of course, I haven't lived in 19th century to say. But.
Right. But you would still say, though, the ability to safely make the box bigger is still important.
Oh, absolutely.
I mean, you could do all of the functional training in the world, but sometimes you're still going to need to make the box bigger.
Oh,
it goes both ways.
Not sometimes, so frequently.
Sure.
But what I'm saying is, that's not the only thing.
It's not the only thing, no.
And I would even dare to say, maybe it's 50%, 40%, but certainly not 90%. And that's the thing. That's where I kind of feel.
In your experience, it's not the case that the body will just adapt and learn to use the space. The person needs to be trained to use the space if they've expanded. The body won't just fill it in like gas fills a container. It doesn't work that way.
No, it doesn't work that way, because you have to build up now the engram. The tongue most of the time doesn't even know where to go. You ask them to put the tongue up, they go like this. They don't know.
They're punching
because they don't have an engram. They have to build up the engram. It's just like practicing, like taking a clarinet and try to play. So for my teacher who gives me classes, to him this is a second nature. That's what he's been doing for 25 years. When I got it 4 months ago, geez Louise, man, I can't even make the fingers go. But now as I practice, I'm not dangerous anymore for my for my wife, I'm not making too much noise in the house, so she can handle me.
Sure.
So what I'm saying is it's a practice, but it doesn't happen overnight. It really is so up to patients or parents. We find that if we don't have a family support, both parents support, and really vested into exercises and everything nothing gets better.
And that's why you have myofunctional training inside of your practice now.
Yes.
You have 2 hygienists who double as myofunctional therapists.
Yes.
And has this changed your patient outcomes significantly? Could you not imagine having a practice without it
This now, knowing what I know, no, I could not do this. I would have to have someone to refer. If I were to do whatever I do orthodontically or whatever dentally, no, it would be marginal. Marginal. It would be half success. Let's put it this way.
Yeah, it's only the form is only half of the battle.
Yeah, but craniosacral therapists also play a big role.
Tell us about that. What is?
I don't know. I just know enough not to belittle it anymore.
Sure,
but I will tell
you have a referral. You have a craniosacral. Is it an osteopath or is it just a craniosacral therapist?
I really don't know. It's way above my pay grade.
Yeah, it is
but
mysterious stuff.
I know that it's so important, but I know also that it makes no sense for them to start before you realize remove the obstacles or etiology that brought you to the point that you don't have enough space, that brought you to the point that you cannot breathe well. So doing it before is like basically going to chiropractor and keep doing it for your back, whatever the exercise. It feels good 15 minutes and then you're going back. And then it seems to me 6 months later, it seems like you have a chiropractor on your payroll. Because it's not solving the essence. It's just teaching you, but then you go back because body adapts. We have phenomenal adaptability, but it comes with a price.
So where does the craniosacral therapist fit into your treatment protocol? After the myofunctional therapy and the expansion, or before, during, and after?
After the first. After about half of the ortho treatment is in, I need to give more space. I need to give more room for the tongue. And then body observes that it's not under the siege. So then the craniosacral, the osteopathic doctor can do certain things to the cranial strains so that their positioning are balanced with the whole body. But again, I'm not an expert, so I'm not going to.
Have you gotten pushback from craniosacral therapists about
No,
expansion?
I'm looking for one that can work with us and come over here and learn what we know. But
Yeah. My experience with osteopaths and with craniosacral therapists is that they don't like the MARPEs, the MSC. They don't like the skeletal expansion. They think it's too invasive, and they end up getting into the philosophy of the tooth-borne expanders because they think it's more biologically friendly, but what they don't understand is the dental side of it, that causes bone loss, root resorption, gum loss, and in general causes dental damage. They think that it's almost like they buy the marketing around some of the tooth-borne expanders that says, oh, this is like epigenetic bone growth, and they sort of buy into that. But this was a couple years ago that I was seeing the osteopath, and so that was just my experience back then. Maybe they've come up to speed about the skeletal expanders. I don't know.
So let me tell you, as someone who has been in orthodontics for like 20 plus years, and I've tried a lot of different modalities. And late Dr. Bob Garrity, he was my mentor in orthodontics. And he started it, and he showed the most beautiful orthodontics I've ever seen. I haven't seen any ortho, even close, as good as him. He was pediatric orthodontist in Bozidar, Oklahoma, and he would bring in the classes hundreds of casts. Say like a person that was young kid, teenager, college student, mother, grandma. I mean, he would follow 25 years with the casts.
Wow.
And stability and those kind of things. But he would go in the interceptive orthodontics right there, bottom. first thing. You don't wait until the whole thing is over. Now, second thing is he would expand with the NITI appliances. It's a soft, how would I say, mild force expand.
Like an ALF?
Well, not ALF. I've done an ALF, and I still think ALF has its own merit.
Sure, I do too.
It's a slow process, and it's not for everyone. I use sparingly, but I still do it. Here is my point about this, about being MARPE or whatever. It's not either or. It's not either or, particularly in early age. In early till about like maybe age of 10 or 11.
Sure.
We really, I mean, we expand with the NITI appliances and stuff with the gentle forces, and it just works as a charm. It's not cranking. So I get the point of craniosacral therapists.
Sure.
They don't want immediate rapid cranks, because they refer and they can feel the difference in the skull. Now again, I don't do that. I don't feel it, but I do get it that there could be something I don't know, but they feel it. So I could see that point, or that old-fashioned cranking is not doing a justice, maybe.
Yeah.
So that's where the slow expanders come into the play, particularly with kids below the age of 11.
Yeah.
Now the problem with that age is that after 11, 90% of a face is done with the growth, and everything becomes much harder. Mm-hmm. Then one has to really start resorting to MSCs, to whatever, consider that at least. And your point is valid about expanding and bringing it out of the bony walls, and then you have to do the grafting and whatnot, and it's totally valid. But I'm here to tell you that not everyone wants to cannot even fathom how to have the say like MSC or MARPE expansion. But I've had the patients. I actually have it now. Patient that is 45, and she just freaked out on thinking about MARPE. As a matter of fact, I have now her model that I didn't install.
You showed her that and she freaked out?
Yeah.
That's a custom MARPE from Partners.
Yes. So now, she said,
it's a beautiful appliance, by the way.
I believe you, I just cannot fathom this. I said, that's okay. So what I do? What's my option? I mean, I'm going to tell her not to treat? No. But she has major problems with the headaches, with the depression, with all these kind of things. So she said, listen, can you just line up and do something for me, short of this? I said, listen, I really think that not only that you need expansion, you need actually MMA for a whole enchilada. But not everyone is for a whole enchilada. Yeah. So we have to go step by step until patient says, hey, I'm okay with that. So what I did say like an ITI appliance for her. And it expanded, and I'm working out the conventional ortho with her doing a myofunctional therapist here. So she says, and those are her words, I mean, don't she said that she feels that her breathing is like 60-70% better than ever.
There you go.
So now while I know that I'm thinking how stable it is, because of the all other soft tissue, but she's feeling better. She actually medically feels better. She said that she has not had a headache in the last 5 months since we started treatment. So this is a medical thing. This is not a dental.
Sure. That's all that matters.
That's what I'm saying. But she didn't start because she hated her teeth. Right. So now we're gonna finish it, and she's gonna she had her own. I did the frenectomy for her and whatnot. So she's much better, at least the way that she talks about us. Now, is she optimal? No, I know that, and she knows that, and I know that the danger of a relapse is there. Now, is it going to be 100%? Probably not, but it is possible. But those are all things, the choices for my patients. I don't shove it into their throat, They have to say, well, this is it. But then I have a gentleman, again, bicuspid extraction before and stuff. He's 32. He opened up in like 4 days. I couldn't believe it.
With the MARPE?
With the MARPE and with the PIEZO cuts. Anyway.
Do you do the PIEZO cut right here in office?
Yeah. And so he said, and those are his words, not mine. I'm just writing down in all charts so I have a reference point. About 6 weeks, 7 weeks into this, and again, this is not to advertise this. It's just that we open up and we know that the airway has a less than a resistance of airflow and all that. It basically down-regulates the sympathetic impact and it feels good. So he comes to me and say, Dr. K, I have to tell you, you don't know, but I am a marathon runner. He said, and we are still about maybe to finish soon with expansion, but he's expanded. He said, my numbers are about 15 to 20% better.
That's incredible.
By just breathing. And he tapes his mouth while he was running. And he said, I had tremendous amount of anxiety during the day. I don't even know why. I don't have a reason for it. But this is the upregulated sympathetic system that works all the time. He said, I don't have that anymore. So now we're doing, and I have my own dilemmas and the problems with the bite and all whatnot. But he said, listen, if this is how I feel the rest of my life, I'm not thinking even MMA. Now, this way, he's not going to be any better. But he feels better. And and I'm doing HRPO, I'm giving him over and over to see how is he doing. If he's doing medically good, who am I to tell him? You got to have MMA.
Right.
What I'm saying is, he's the one who's going to say it. But if he says, listen, this is so good, probably can be better, I'm willing to go for it. Now he's ready to go, and I can send him to whatever Mass General, whoever does it, and they can do now. But I can show you a case that they did MMA without expansion, and it's a conundrum on a 40-year-old that hurts my feelings, but I can't even I can show you only when we close this.
No problem, but basically, if I could pry a little bit into that case more, he did MMA without doing the maxillary expansion.
He didn't. They told him this is the only way out.
Yeah, and now he's wanting to expand the
No,
nasal
now he is in so much more misery. Now you see, it ends up, it's compounding. In the beginning, he had a problem with the breathing, maybe, but then it becomes a problem, heart tissue dysfunction. Then it becomes a problem now, the tendons, and now it vertigo, and then the buckle, all kinds of things. What the gentleman went through in 15, 20 years, it's beyond my, but I will gladly show you.
Sure. Wow.
Is there a cortisol release whenever you have sleep apnea?
Well, this should be one of the tests to be done. AM cortisol, yes. AM cortisol, and eventually maybe high sensitivity C-reactive protein. Those are the markers for the one of the markers for inflammation. And you know what? When you have a low-grade sympathetic overdrive, a low-grade adrenaline seeping in your body, well, guess what? You have all signs and symptoms of anxiety and all these kind of things with everything else. Coldness in the hands and feet, constipations, heart, all kinds of things.
And do these people go for sleep studies before they come?
Well, the problem is that I tell them, when I see my patients, I say, listen, go do for a sleep study and then we'll see. But at least, I tell them go. But I also know many of them, they will fail the test because they are not OSA. Medical system knows you don't even have a problem or you have OSA. But OSA is like a stage 3 and 4 cancer. So what is in between? So they go like, they told me I don't have OSA. So it basically implies you don't have a problem.
What's OSA?
Obstructive sleep apnea.
Oh.
But then they don't know. The medical system doesn't have the answer from problem to OSA. That's the thing.
Yeah.
And then when it comes to OSA, We have what do we have? CPAP. Well, of course, God bless it, because it's immediate and it helps people. But the problem is 50% is CPAP intolerant right from the get-go, and 2 years after usage, 50% of those that could tolerate are not. So basically, medical system has an answer that fits only 25% of people, and this is only present.
That's tragic.
So, like, when you do the sleep study, you have to meet a threshold.
That's it, yes. That's insurance goes. That's how they go. You have this many OSAs and stuff, whatever, 10, 15.
AHI, 10 to
AHIs
15.
and stuff, yeah, and then they start. And well, of course, they have a more sophisticated, appliances, they can, instruments that they can say, if you have maybe, God forbid, central also and stuff like that, it's another level of problem.
Right.
But involving a sleep specialist on a different level than what it is it would be of tremendous help. But that's almost like kind of a governmental question, because it has to be done on a different levels. Who has the time to do it?
I know, because what if one day you have sleep apnea really bad and the next day you don't? You go in for that study and that day you fail.
No, it's there are many signs they can see it.
Mm-hmm.
I personally think you are completely right. It should be done at least for a few nights. When we do HRPO, we give for 4 nights, and we have a sleep log. So you tell me, did you have alcohol or not? Because if you have a glass of wine before sleep, man, let me tell you, your numbers are 30-40% worse.
Oh my gosh.
Yeah. So, or if you had a meal, particularly a carb-loaded meal, pastas, pizzas, those kind of things, sweets, they change quite a bit.
Wow. What's the mechanism there? Why would food late at night cause you to have worse sleep breathing?
You cannot go in, because you see, the thing is that if you load yourself with the carbs, the body has to metabolize it. By metabolism, the heart rate is elevated 20%. As it's elevated, you have more body temperature, and in order to fall asleep, 2 things have to be satisfied. Only two. The melatonin has to start kicking in, and the temperature has to go 2 to 3 centigrades down. Now, how do you do this? You can't do that because your body is working. So that's why when you have a baby, don't try to kind of wrap him all the time, because that's how it wakes up. That's why babies' feet go out. They want to maintain this. That's why babies fall asleep after a hot shower in the evening, because it evaporates the heat and the temperature inside drops down and they fall asleep.
Well, there you go. We were actually just talking about that, because Alexis and I like to sleep cool. We keep the window open. Our temperature in our room is like between 60 and 65. It's low. But then we're worried, is the baby going to be able to handle this temperature?
Baby's going to thank you for that.
Well, there you go.
So this is another level, and this is very good that you kick that. So it's a sleep hygiene. Someone has to talk about a sleep hygiene. My wife was just spending a night at her sister's home here in a neighborhood of Boston, and she said she had a problem sleeping. I said, why, honey? She said they have already decorations for Halloween, and it was outside all the time. We sleep with a pitch black. All shutters are closed. We don't have any electronic device with the red things and stuff like that. We have actually a problem even going to hotels. You know how the TV and stuff. We could not believe how much it matters in sleep.
It does.
But yes, you are completely right. Our room is rarely, never over 67 degrees.
Yeah. Sleep hygiene is huge, and we have a very carefully manicured sleep environment. Very dark, very cool. If it's loud around us, we put on the white noise. We sleep on an incline, and other things. We turn the lights down very dark for about an hour before we sleep. We even take a red handkerchief, put it over the lamp, so that the light gets even redder and warmer for like an hour before bed.
Light. Don't do any LED. LED kills. Do you know how an LED? It's basically blue light.
It's
that actually through the iris goes and it lowers the melatonin and regulates down regulates melatonin. So melatonin kicks in, right? And that's when we start yawing and whatnot, and we're getting ready. But melatonin, unlike, people are taking it randomly, and doesn't seem like it helps, because melatonin helps only for people that change their time zones. That's when it kicks in. But in the same time zone, it doesn't do much, because melatonin is like, to use a comparison of a Dr. Matthew Walker, he said, melatonin is like a sprint race, but the melatonin is the guy who has a gun and says 3, 2, 1, bam, start. It says when it starts. It has nothing to do with the sleep itself. But melatonin, when melatonin starts going up, that's when we want to fall asleep. The problem is with the blue light. Blue light actually suppresses. So how many times did you go to bed with let me just check 2 more messages on my phone, and you can't sleep? Yeah. That's what it is.
Yeah. Wow. Yeah, we're actually building a home, and we're being very careful about our lighting choices. And so one feature that I'm getting in the lights for the house is, it's called dim to warm. It is an LED, but what happens with it is, as you turn the dimmer down, the color temperature of the light goes from 3000 to 2000, which more mimics the sun, because as the sun gets dimmer in the evening, the color temperature of the sun also gets more red. But I'm curious if LEDs, even if it's like a red LED, if it's actually giving a true blue light, but it's somehow just masking that. I'm going to have to look into that.
I don't know that.
I mean, incandescent lights are absolutely more pleasant, but they just consume so much more energy. In the state of Massachusetts, like, they basically won't even let you do it. They'll take away this building incentive that they give you, but to get the incentive, you must use LEDs. But I'm going to definitely look into that.
I really don't know the answer to that.
Yeah,
but this is a sleep hygiene. There's a lot of other small things, but that's what brings us to another level: a lifestyle. I measure myself for the last 6-7 years. I walk to my office every day, 2.7 miles each way, and I'm working all day long.
But you walk to work?
Walk, yeah.
That's incredible.
That's so good.
And I see how I sleep, because I measure with the watch. I measure my quality of my sleep with the deep sleep and whatnot, and also with the snore. And I tape my mouth and whatnot. And I can tell you right away, all things equal, if I do not have physical activity, then my sleep is easily 20% worse. Easily.
Have you ever turned away a patient who just has whose lifestyle just doesn't fit your
Well, you see, it's kind of it's almost a moral / business decision. No, I don't turn them away, but I do make clear that what are the consequences, at least within the mouth. I mean, I can't go further than that. I tell them, hey, you are clenching, for example, or whatever, you are drinking, whatever. These fillings I'm closing the potholes. They're not solution for everything, particularly not solution for stupidity. And if you do this, I'll gladly do another filling, and I'll gladly do another crown, and I'll gladly do the implant. I live of this.
Sure.
But you're not willing. You choose how you want to do it. So basically, I make it very bluntly clear what to expect, but no, I don't turn them off. I don't turn them off.
You do have the tough conversation with the patients, though.
It is because you know what? If I don't do that, it comes back to me, and then I start owning the problem. When you come over here, you have a problem. But when we start working, then we have a problem. I don't like problems.
Yeah. Doctor, if I could take this as a segue, so I'm starting a new section on my channel called JawHacks Baby, where I ask for advice for raising a newborn baby. So this is the first JawHacks Baby segment. We can keep it brief, but while we're on the subject of lifestyle, what do you think about kids eating candy? Because I see it very common. The parents use the candy almost as a way to control the kids. Talk to me about that. How bad is that for a 2-year-old to be eating Skittles, for example?
Well, being a kid of 60s and 70s when this was so prevalent, you know what? I'm just writing some paper and stuff, and I can't comment about this. I just feel that we blew it out of proportion, And I would like to see a study that ever was written that it says candy equals cavities, okay? Candies themselves are bad to begin with because of high content of sugar. And it gives kid one disarray. First, it keeps him in a sympathetic, it's a stimulant. Sugar is stimulant. If a baby is 4 or 5 months old and we need to release his tongue, I don't do that, I refer that young kids. What they do, they don't make him numb. They give him a honey or sugar. And they do the release. So think about how potent stimulant is. It's a drug.
Sure.
That's why we can't live without sugar.
It's my favorite kind of drug. I love stimulants.
But from that perspective, I think it does whack in a way of metabolic syndrome, and it raises a big possibility of metabolic syndrome soon into life. So that my problem is medical concern rather than the dental concern.
Interesting.
You know.
Interesting.
Now, what am I gonna say? He's not gonna have a cavity. No, if he gets a cavity, young kid, not baby, but young kid, if they all thrive on the carbs, there's some problem, huge problem. It's addictive problem. That's how they do it. Because if they didn't have a good sleep, they're gonna crash. They subconsciously, without knowing, having a knowledge of a chemistry or other natural sciences, they reach for it. That's why they want to eat pastas and pizzas. You know, give them some vegetables. Good luck, because vegetables take a time to metabolize.
They crave the rapid release blood
Absolutely,
sugar.
that's what they need, and that's how they get joy. That's their fix. And then, of course, they don't want to eat what they need to eat.
Even adults end up on this sugar cycle.
And then they don't thrive in a growth. Their cognitive abilities are not up to par. Their behavior is a serious problem. But parents become aware of this only when they start with the school, because school is not going to put up with that. So it only gets, as opposed what majority of people say, oh, little Johnny will grow out of it. No, they grow into it.
They become more and more deeply addicted.
It just becomes they are finding the ways how to cope with the continuous lack of energy, because their bodies from the get-go is not working the way it should, physiologically, metabolically.
Yeah. Saying that a kid will grow out of a sugar habit is like saying that someone will grow out of a cocaine habit.
Yeah.
The more you do it, the more deep you go into it.
Yeah.
Okay, so we're clear on that. Now, our baby is going to be born any day now, actually. Definitely within the next week or two. As soon as that baby is born, specifically with regards to the tongue tie, what do we look for to make sure that...
it should be breathed, conditionally speaking, for baby and a mother. Mother should have a milk, and baby goes, and baby does what baby does. Sleeps, poops, and pees. That's it. That's it. Simple as it is. And, as opposed... my ex-wife, who would claim, oh, he's a little fussy, and I'm thinking, how fussy could be 3-week-old? I mean, what's to be fussy about, right? No, they are not fussy. Something's missing. And if baby is nursing, and it's quiet after, that's it. But the moment, so that's why I do not stop asking parent or patient if you were been breastfed. But I also ask now, did your mother have problems nursing you? Because mothers sometimes persevere in something they push through, but it shouldn't be a problem. If she had a problem, or say like I had not a patient, and I called his mother, say he was nursing that was fine. For how long? For 4 months. And I said, what about that? Why did he? Well, it doesn't seem like he was interested anymore. So I would have almost bought into this if I'm not kind of crazy analytical, and I'm thinking, what's not to be interested? This is a matter of life and death. 4 months old, doesn't have teeth. So either he breastfeeds or he dies. Past before
in nature.
In nature, right?
Yeah.
So this is not about his choice. And then slowly but surely, this is a kid now. Well, he's 24, 5, 6, very intelligent. They're gonna do now third time ortho. He needs some expansion, even though his arch is like this big. But problems with the jaws and clicks, not one single cavity in his head. But that's what I'm saying.
So what are we saying? He has poor facial development, and that probably goes all the way back to that 4-month-old age where something was off. He was having trouble latching.
Yeah.
And
he actually he went to a friend of mine in Staten Island, and they started with the myofunctional therapy first. Myofunctional therapy. Nothing else. And he's already 50% better.
Wow.
Think about this. He needs Ida. He needs some other things. But I'm telling you, that's how. He's 50% better with all his symptoms just by with the myofunctional therapy. Mm-hmm. So think about this. But this is not on a radar of dentistry. It's too elusive.
Right. Dentists are used to having discrete objectives that they can achieve. The cavity is filled, the teeth are straight, the bite is aligned.
Margin is perfect.
Myofunctional therapy is more like physical therapy where you have to be okay with having soft goals and just having subjective patient experience feedback.
You have to be evaluated. You have to be measured. That's what I'm saying.
Yeah.
What's the examination like at the baby's first appointment when they check for the tongue tie? Do you feel like they don't check enough?
But you
at
see,
the hospital.
This is ultimate test. Can he nurse or not? Can he latch or not? That's it. Simple as it is.
Comfortably.
Comfortably, yes.
But like when you say, oh, it's a fussy baby, it's not just a fussy baby.
No, it's not fussy baby. Then the problem is he cannot. My one of my boys, he said, my wife said, man, you know what? I don't know. Maybe anatomically I'm this. I said, no. We thought it was mom's problem. It's actually not.
She thought it was maybe
that's it. Yes.
Her breast.
Yes, it is not good, and it's actually turned out that he had the problem all along. But he would go, but it seems like he never enough. Because he cannot get. Right. You see, the thing is, how Almighty created us. I mean, he has to go around the mother's breast like to make a suction, and then has to press with his tongue. This is a labor. That's why healthy baby breaks the sweat while they're eating.
Wow.
Yeah,
did you know that?
It's an exercise.
A breastfeeding baby will break a sweat.
Yeah, they get really hot. That's why they fall asleep. You have to keep them cool.
No, he has to press with the tongue against this papilla incisiva.
Right behind the upper front teeth.
He has to press mother's small nipple that is small. It has nothing to do with the CVS thing. So he has to press it to get the food. But by pressing, he's expanding the arches on all directions. He's lowering the nasal floor. Plus, as he's pressing papilla incisiva, he's actually, there is the connection with like a neurological modulator and releasing the endorphins. Endorphins are, you're calm. And then all of a sudden you put him on a mother's breast and the baby's
knocked out, milk drunk.
That's what it is.
And they say
so. It's to me, it's like kind of baby either does what Almighty created him to do, or it's up to us to figure out.
And so, if a baby immediately you're noticing trouble latching, fussy baby, not eating enough, what does one do?
I don't know. I'm not the expert in this, but I would just look for the tongue tie. Or the buckle ties.
Yeah, because how many tongue ties are we talking? How many ties?
So you have 3 in upper, 3 in the lower outside, and underneath the tongue. Because think about this. This one, you see the front one? If it's too low, okay? When he goes over the mother's breast, it cannot. It is actually a point of leaking. Suction. So you can't.
It breaks the vacuum.
That's it.
Wow.
And then they're taking in air. And then they're colicky.
Here you go.
Wow.
And then they're gassy.
So I mean, I'm not expert. We don't deal a lot with the babies. We refer those, but it's a physiological. This is not something new. I mean, this is for the last 200,000 years.
Are there professionals who specialize in helping babies feed better? I think I've heard of lactation
consultants. I think, yeah.
And there's dentists who specialize in frenectomy and lip and buccal tie releases for
infants.
I
don't know if I would say specialize it, but they learn another skill that can help those kids and babies. We do this, but not the babies.
If we need a referral, we can contact you.
Yeah. We have few places that do this. Okay.
If you were to ask a pediatrician, do you think they would know about buckle ties and things like that?
I don't think so.
I'll take my fifth.
I don't even think they know about the importance of breastfeeding.
It's too much.
Certainly 30, 40 years ago they did.
Well, they'll go into the nutritional aspect of it, but they probably wouldn't think about the mechanical.
Yeah,
That's right.
It is.
That's right.
It's a
They understand there's something special about the chemistry of the milk.
Yes.
But they don't understand what you were explaining about the vacuum and how the vacuum not only draws the milk but serves as the natural palate expander.
Yeah. And then tongue builds engram the day baby comes out of.
What's Ingram? You've mentioned that before.
It's the little say like you're learning to play some instrument, right?
Yeah.
And if I say put this finger here, put this finger here, it's just not natural for you because you don't have the ingram. You have to think about it. You have to watch it. You have to
coordination.
Coordination. But then you practice, and then you don't have to watch it anymore. And then you're talking about this and you're playing.
Yeah.
You created an ingram so that it's basically semi-automatic.
Yeah. And so you're saying that the breastfeeding activity creates a kind of skill for the baby, a kind of coordination that follows them their whole
Tells
life.
where the tongue has to be.
Yeah.
Yeah.
Wow. It's so important.
It is the most important.
Yeah.
And think about what an irony. I mean, we have teeth, we have bone, and we learned quite a bit about it. I mean, we are so sophisticated with all the toys and whistles. But in two dental schools that I went through, and many probably to this day, we actually, when it comes to the soft tissue, tongue, we only know, is it a cancer or slew of conditions for which none have distinct etiology, hence we are dealing with them kind of, it's going to go by itself. Oh, you can take some kind of a management, don't eat this, or take this, Motrin in Taiwan, thank God we have it over. So it's basically, we don't really learn anything about the tongue.
Wow.
We don't really learn anything about the cheeks.
But they determine
Or
everything.
let alone about the lips. But man, we have the big enterprises building up with the fillers, with the Botoxes, with all kinds of things. Think about it. It's the movie industry. It's all thrives on the Botox and fillers.
Yeah. Everyone wants bigger, puffier lips.
Yeah.
What they don't realize is that the right way to get puffier lips is to put bone structure behind them. Is that right?
That's it. That should have been born, right? But if you miss that age of 11, then MMA is the only way to go. Otherwise, you have to go on those fillers. It seems like you just took your head out of the beehive.
Yeah. Is there any other, honey, do you have any questions for the doctor, or are there any other tips that you would give from a facial structure perspective for the first weeks and months of infancy? Because I know you have children.
Oh yeah, I have only 4.
Wow. God bless them.
But no, food is essential.
Just the baby should be able to feed comfortably and in abundance.
And the moment something starts, you're giving him carrots, you're giving him a meat. My boys were eating like lamb chops on their own with a year and a half, not even.
Are you tell me about the weaning process. Are you familiar with this concept of baby-led weaning? Have you heard of that? It's like this idea that instead of giving the infant pureed foods, you go right from the breast to giving them full, for example, a leg of chicken or a piece of beef, and then you just give it to the child. You don't worry about the choking, and you let them eat it the way they want to eat it. Yeah. And they know how to eat it safely.
I mean, I can just go by my common sense, and that doesn't mean it's scientific, okay? But to me, it's like, when I don't have the answer, I think of how almighty... You see, genetically, we are designed to have a teeth at the age of 6, to have at the age of 1, and to get another set starting at the age of 6, to grow, whatever. There are certain genetic message that we cannot change. And when I don't have the answer, and like this question, I would say, Say like your baby is born 200 years ago.
Mm-hmm.
200 years ago. There are no processing food. You're lucky you have something to light the fire.
Sure.
You don't have formulas. What do you think? How would they eat?
They either breastfeed or they eat what everyone else is eating.
And then after that, yes, you just make a smaller pieces and they start eating. But think about this. If they eat food that is chewy, this is the strain. We need stimulus for growth. You cannot sit down and be 6'5". You have to jump. You have to put your bones under the stress. So that's why when we chew, our bones, particularly maxilla, buttresses and goes this way. But we can't even see those anymore. We are lacking the reference point. Even Dr. Price 100 years ago from Case Western, he had to go across the world to find the reference point because he could not find the reference point in the United States.
Right, Weston A. Price.
Yes.
Yeah, so what you're suggesting is that our standard for what we call healthy is distorted.
Oh, totally.
We consider unhealthy to be the standard for healthy. Whereas we should be doing what Weston A. Price did. We look to more traditional peoples that have preserved natural ways of life, and we look at their structure and it's always incredible. 32 teeth, big beautiful faces, wide maxilla, no breathing problems, no back problems, and we say, what do they do?
Well,
yeah.
But you know what? Preservatives and sugars are major suppressors of a cortical bone, and that's why you see. I mean, every other person is like this.
Yeah.
Look at our politicians. You'll see how they don't have a maxilla. It's all, but
they also have no soul.
Well, that's another. But look at that. Look at the beauty industry and look at the faces, and put the Bolton Norths. None of them fit by far. But you see, we got to know if 9 people do it, probably this is a normal. Well, it's not normal. We don't let a chance that could be something different, and that 9 out of 10 are wrong.
Yeah.
But that's another philosophical.
Well, one thing I did want to pick up on is you said that sugar is an inhibitor of was it
cortical bone?
Cortical bone, so bone remodeling, bone growth,
grow.
Basically.
You need the cortical bone to grow.
So then there is also a chemical component to bad food. It's not just that it's soft.
Preservatives
it's also,
and sugar.
Preservatives and sugar will also, even if it's tough sugar, like let's say Jawbreaker candies, where you put a ton of stimulus.
You get a stimulus in the term of the biophysics. But you are making a big rack in a biophysiology.
Right. So you're taking one step forward and one step back.
So you're trading one risk for another. What's good about it?
Right. Wow. I mean, that's definitely something that's under discussed on my channel is the chemical component. Because, of course, everyone talks about the chemical component. Weston A. Price talked about the chemical component, the importance of proper nutrition, but what's rare is the discussion of the mechanical stimulus. But it really is both.
Did you hear about Pottenger's cats?
I've heard of it, but tell us about it.
No, I would paraphrase it, probably butcher it. But
okay.
Pottenger, their foundation is the same now, along with the Dr. Price's. We're about the cats that he changed. He took a 50% of cats and fed them with the cooked milk and the raw milk. And then observe the first generation, second generation. The one that was cooked already had, I don't know, a certain percentage of less of offsprings, shorter life, smaller in the size, and all these kind of things. But it all goes against the food industry, and it's been going on for a long time.
I know.
We are not saying anything.
Yeah, well, we live in a dark world, unfortunately, but we have to be.
Bozidar will do something at least, but this is some way. But that's why I'm saying this is not the only way.
Sure.
And certainly presenting this and not tapping onto bigger picture, I don't think we're doing a complete service to the public.
Yeah.
Maybe to get a short interview with my hygienist, like myofunctional therapist.
I would love that.
And Becky, who is the manager, who's really knowing those kind of things. I think it would be phenomenal.
I would be happy to, and I think that would be great content, very informative.
Yes.
And good for everyone.
Yeah. So why don't we do that?
Okay, let's do it. Doctor, thank you. You mean today?
You.
Today do it?
No. They're not here. We
Okay.
will just schedule.
Just reach out to me. You have.
Yeah. So we
Alicia
have this.
has my
Alicia
phone
is
number.
Alicia is the one who works all the time, and this is you met Becky.
Yes, Becky brought us
This
in.
is
Yeah.
this is everything starts and ends here.
That's awesome.
She likes you. You are golden.
Oh God.
You're already in.
All right.
Can you tell what she had?
Yeah, she has a.
Right now.
Wow, good for you.
Yeah.
How do you
Doing well.
How do you feel? Good.
I do feel well. I feel like my sleep is a lot improved, and my breathing is also
Wow.
improved as well.
Wow, very good.
And
I
already
had
did
one of my own.
2 rounds of ortho since she's been working. She's been working for a few years for me.
Good. You're in good hands, it seems.
And yes, your things are in this next room.
Okay, thank you.
Bye.
Good luck to you.
All right,
you.
so come. You know what? I'll have Alicia reach out this week, and then you guys pin down whenever. I would assume that if you were to basically take a little tidbits and bits from each, they work Tuesday and Thursday full day, and we can make it like their lunchtime, whatever.
Perfect. Be in and out.
Okay, in and out, and then that's not the problem to have a Becky on the side, and she can talk about some kind of issues and stuff like that, how it goes about in this practice. It's just kind of a little, not like a really used car dealer type of marketing. It's just informational.
That's it. That's it. Useful
Information,
information
yes.
for patients
Yes.
who are looking for these
Yes,
services.
yes.
You know, the people are needing and looking for these services, and especially myofunctional therapy. There's not a lot of good stuff out there, so that's someplace I want to look more deeply.
I think this is. I'm gonna contact you with Kim and Tracy.
Awesome.
Those are 2 dynamos.
I will be looking forward to that, and we'll get them on this fall before in this next round of JawCasts that I'm going to do before I start my job again in February.
Perfect.
Okay?
Perfect.
Doctor, thank you for your time today. That was awesome. Great
pleasure.
information and very pleasant.
Yeah.
Beautiful practice, beautiful artwork, and
thank you.
also excellent hospitality for my wife and I. So thank you so much.
Thank you very much. You guys are more welcome to come anytime.
Thank you, Doctor. Okay, we'll see you.